Hi, welcome everybody to today's session, and welcome to the Cardiac Prevention Healthcare Million Hearts webinar, and thank you for joining us. Before we start, we have just a few housekeeping items for you. First, we'd ask you all to please mute your lines. Do not place them on hold. If you need technical assistance with the chat feature, you can contact me, D. Kennedy. But before we start, we are going to mute all the lines. All lines are muted, so during our question and answer period, if you have a question, we ask that you do it through the chat function, and we will present them to the respective speakers. Okay? After the webinar, you should all be able to download the presentation directly from the website, and we will forward you that link following the webinar. Again, we would ask you not to put your calls on hold, but to mute your phone. And without further ado, let me introduce you to Dr. Adrienne Nim, our host for this session. Thank you.
Thank you all for joining us today. I have viewed these sessions to be very collaborative, and this is the third in the series of our clinical leadership discussions about areas of work within the QIO. We have reserved these times to be specifically only QIO discussants and participants because we felt that it would be helpful to collaborate within our own community about how we're doing quality improvement. This whole clinical discussion series was conceived by the Physician Leadership Network. The Physician Leadership Network, or PLN, is a subgroup of physicians across all QIOs that are convened through the Trade Association of ACWA. We felt that it would be of value for us to have discussions about the topics that we are working on now that may go further into the next scope of work, and that we would be able to share our experience across disciplines, not just physicians or others, but to have a breadth of people on the phone. So for that, I have actually posted a polling question, which you will see come up on the right-hand side of your screen. And this gives us an idea of who is on the line today so that we can then broaden our approach when we're having our discussions. So I'm going to ask Ashley to put up the polling question so that people can respond to who's on the call. We have done a sincere effort of getting a broad reach of people from CMS to those who were physicians and others. So the polling question has now come up. Please indicate there which role that you actually participate in right now in your role working on the QIO. When that's complete, we'll be able to see the answers from that poll, and that will give us a better idea as we're focusing on our discussion how we would want to include others in the work that we do. A second polling question would go up shortly thereafter, which would look at whether you're currently involved in Million Hearts. We were trying to get a broad array of people involved in our discussion because we know although this is the work of C9, there have been others who have been working in this work on care transitions or adverse drug events. So the results of the first poll show that we had quite a good variety of people who were involved. So please answer the second poll now so that we'll know which group of people are on the line. Whether you're very involved with the C9 work, moderately involved, or not involved at all. I would say that the reason we've had these sessions is because we know that you on the phone are the boots on the ground, that you're going across the country listening to our providers, listening to the Medicare beneficiaries, and trying to improve the cardiac health of our nation. We know that we can be very successful in this effort if we work together. So the poll will be closing. We'll get a better idea of who's actually on the line today as we then move forward with our discussion. So today the host that will be leading us is Jo Nickham, and she's from the Arkansas Foundation of Medical Care. We appreciate her leadership in this, and I will now turn it over to Joe. Joe, you press *6 to unmute your line.
Thank you, Dr. Mims. The focus of today's call is to share successful strategies used by 5 selected QIOs to address the National Million Hearts Initiative goals. These 5 QIOs were selected by the IHPC NCC based upon the following criteria: meeting and or exceeding their recruitment targets, their unique partner mix, their Million Hearts Pledge activities, demonstrating innovation, and ability to capture practice cardiovascular data. Following success stories, we will transition from these to presentations addressing identified barriers specific to the prevention and or treatment of cardiovascular disease. Following the barriers discussion, we will be open for questions and answers, and we ask that you hold questions until that time. It is my privilege to introduce each of our 5 panelists today, and we will begin with Devin Detweiler from the Colorado QIO. Devin's been working in healthcare setting her entire career, including cardiology, endocrinology, internal medicine, and family practice. She has more than 15 years' experience in practice management and has taught in the medical office technology program at Front Range Community College. She's been working with electronic health records for the past 7 years and working at the Colorado Foundation for Medical Care for 5 years. Devin?
Great. Thank you so much, Joe. Thanks, Dr. Mims. Thank you for letting me be here today. Go ahead and go to the next slide. So our goals were basically 38 provider practices. Year to date, we've recruited 44, and our goal is to actually reach out to another 20 practices over the next year. The time frame of our program is the whole scope of work from August 1st, 2012 until the last day, July 31st, 2014. Right now, our target audiences are outpatient providers working in adult primary care, OBGYN, and cardiologists. And I think a big part of our recruitment success has been to continue that relationship that we had providers from the 8th scope of work, the 9th scope of work, and then we were also part of the Meaningful Use Rec program. And we're hoping to keep those relationships going with the cardio work in this scope of work and moving on to the next one. Next slide, please. So the partners that we're working with, we've got an Avista Integrated Physician Network, the Academy of Family Physicians, the Cardiology, College of Cardiology, Colorado chapter has been really helpful. American Heart Association, Cancer. We've been lucky to work with at least 3 or 4 of the different departments in our Department of Public Health and Environment. We've also been lucky to work with providers at the University of Colorado in several different programs. Next slide, please. So basically, our key messaging is data, and I apologize, this is really hard to read, but this is an example of data collected, benchmarked, and that we share back with the practices. So the first group of colors is one provider over the 4 quarters of the year. So that low rate is basically just the first quarter. The second color, the darker blue, is through the first 6 months. Then that kind of marine color is through the 3rd quarter. And then the green is for the whole year of 2012. So this particular measure is LDL control of less than 100 in patients with a diagnosis of IBD. So this is one practice. These are the 7 different providers in the practice. So we graph them individually. And then we also provide graphs of the practice averages to all the practices in Colorado. So we compare them to other practices. And then if there is a national benchmark, we'll also do that line above the top so that practices can see and hopefully goal set. Next slide, please. So our other key messages are basically awareness. We've been really lucky to collaborate with the Colorado College of Cardiology on their Million Hearts. Dr. Janet Wright was actually here in Colorado and was our keynote speaker. We have a weekly newsletter that we put in, articles, events, and tools. We've had a few excellent webinars. We've been lucky enough that Kaiser Permanente has been recognized nationally. So they actually did a webinar for us to share best practices. So that was kind of an education as well as a best practice webinar. We had one of the cardiologists from University of Colorado do a CVD risk factor management webinar. And then we also worked with the clinical director of National Jewish Health, who's also the person in charge of the quit line here in Colorado for tobacco cessation. And then again, to share in best practices, we have the Kaiser success story, and we are also running articles in our weekly newsletter highlighting the practices, showing the best relative improvement, and trying to ask them what their practices are that other practices can do. Next slide, please. So best practices, data collection and visual benchmarking. And the use that we basically use these clinical quality measures to report and engage practices in PQRS, meaningful use, and to report them to third-party payers. And we like to highlight and use best performance. Lessons learned and best practices need in-office technical assistance to actually pull that data out. We like to reach out to stakeholders to promote collaboration, coordination, and statewide messaging. And then our next big goal is going to be try to involve or recruit an entire community. So working with the C8 group to go in and message this to the whole community. Next slide. Thank you very much. I hope I kept it under my 5 minutes.
Thank you, Devin. Before I move on to the second speaker, I'm going to go ahead and go over today's learning objectives. We hope that following today's call, you all will be able to describe successful strategies used to promote and support the Million Hearts National Initiative to prevent 1 million heart attacks and strokes by 2017. We hope that you can describe some successful interventions used to address the ABCs of million hearts. We hope that you can identify barriers for preventing cardiovascular disease and or improving cardiovascular health in both communities and populations. We hope for you to identify barriers to improve heart health at the patient level, the practice level, and the systems level. And we hope that you can consider or reveal solutions to barriers at patient, practice, and systems levels. So we'll move on to our second presenter, and this is Donette Branch from the Maryland QIO. Donette is a certified professional in health information technology and certified professional in electronic health records. She serves as Maryland's QIO project manager for Delmarva Foundation, Improving Health for Population and Communities team. She has more than 25 years of experience in health administration, social services, public relations, and education. Donette works with medical practices along the total continuum of HIT adoption, from assessment through care management and reporting of quality measures. Welcome, Donette.
Thank you. And thank you for the opportunity to provide a high-level overview of the collaboration between the Delmarva Foundation for Medical Care and the Maryland Department of Health and Mental Hygiene to launch a statewide cardiac campaign. Next slide, please. Our goal was to maximize Maryland's efforts to prevent and control cardiovascular disease, and to do so by providing interactive panel discussions on clinical and community strategies that save lives from heart disease and strokes, with a focus on hypertension control in varied healthcare and community settings. Our target audience was representation from providers, payers, public health, employers, community-based organizations, schools, and child care. Next slide, please. Listed here are our key partners. As you view the list, some of the partners are fairly obvious: local health departments, FQHCs, as well as the AHA and the ADA. MedChi, which is Maryland's Medical Society, along with the Maryland Learning Collaborative pilot, were very instrumental in garnering physician support. Scripture Future Baltimore is a national campaign in 6 targeted cities promoting medication adherence. Next slide, please. The Maryland Department of Mental Health and Hygiene approached the Delmarva Foundation in the summer of 2012 with the idea of partnering to launch the Million Hearts Initiative in the state of Maryland. A Maryland Million Hearts kickoff webinar was planned and conducted in November of 2012 to introduce the campaign and to spark interest for the upcoming Maryland Million Hearts Symposium. About 120 persons registered for the midday webinar. Delmarva and the Department of Health and Mental Hygiene each discussed our strengths and went about jointly planning a day-long summit that would enable attendees to learn and to share strategies that save lives from heart disease and stroke. Next slide, please. The results. The day-long event took place on Valentine's Eve Day, February 13, 2013. There were 52 speakers and panelists, including Dr. Janet Wright. There were 3 breakout session tracks. The tracks were healthcare, worksite, and community, schools, and child care. Over 360 attendees had the opportunity to learn as well as share best practices to overcome barriers and strengthen cardiac health across Maryland. Just to note here, our goal was to have 200 attendees. When we closed registration the week before the event, we had 300 registrants. We had to reopen registration, and registration actually closed at 400 attendees. Finally, the work of the QIO was introduced to new audiences, including local health departments, employers, payers, and community-based organizations. Next slide, please. What did we learn? Well, it's important to become familiar with the way that the partner organization works, their unique processes, deadlines, and contractual obligations. All of our meetings were virtual, lots of conference calls and lots of emails. Because we had not worked together before, open communication, developing trust, adhering to and respecting deadlines proved key to our success. Opportunities for planning, creativity, and thinking outside the box are endless when partnering with an organization that does not think or function like your own. In conclusion, we embrace CMS's operating value in working with partners outside our usual boundaries. This collaboration brought together 2 entities with similar goals who leverage their resources, contacts, skills, staff, expertise, and relationships to plan and conduct a statewide event that successfully achieved the goals of both organizations. Thank you.
Thank you, Donette. Our third panelist is Carolyn Wojciela from New Jersey. Carolyn is the Director of Information Services and Physician Office Program Lead for Healthcare Quality Strategies, Inc. She joined HQSI in 1997, and her current responsibilities include providing technical assistance and support for physician offices to help them analyze and redesign office workflow, improve efficiencies and effectiveness, and enhance patient-centered care. Carolyn?
Hi, good afternoon. Hope everybody can hear me. Next slide, please. Our goals of our kind of the way we approach the Cardiac Learning Network was really to create a greater awareness focused around smoking and the smoking campaign in New Jersey. We found that we needed to kind of give providers a way to hone into one thing that they wanted to do. So we engaged partners kind of to look at what they were doing overall in New Jersey with smoke-free parks, facilities, and also trying to reduce smoking or improve smoking cessation activities. What we did was we fostered some relationships with community orgs that are local to us through the Eastern Division of the American Cancer Society, New Jersey GAP, which works on smoke-free facilities and parks, and the Center Prevention and New Jersey Quitline, which offer educational programs for providers and also offers free smoking assistance to patients and providers to refer their patients to that. Next slide, please. A couple key messages. We kind of put together a message that had a patient focus, and a lot of our brochures, our posters, and things that we give our providers focus on 2 things. For the patient, it's a cause for conversation. So we do smoking, a cause for conversation. We did a provider focus, asking them to join the conversation, become a part of the overall goal of helping to help their patients become smoke-free. We linked our messages together sort of with health facts. We did Do You Know Your ABCS and how to reduce your risk for heart disease and stroke. Do you know what happens when you quit? And we have a clock that ties that message together that looks at the 60 minutes and what happens when a person quits. And we also did Where Can You Get Help? Basically trying to help a patient use New Jersey quitline. Overall, our plan for implementation is we reviewed smoking stats in the states and identified areas that had the highest percentage of adult smokers. So we had 4 counties that you can see. We had one county, Warren, that really wanted to partner with us and promote it as a community-wide effort. Their emphasis was on smoke-free areas as well as young adult education, because we have a growing number of young adults smoking, and using other tobacco products like e-cigarettes. So what we did is we developed a trifold presentation board for the hospital, along with handouts and other materials that they displayed in their cafeteria. And basically, it's been in there for about 2 or 3 months, really just driving patients to providers in the community and also just informing our message. Next slide, please. Some of the best practices that came out of that, we actually had requests for a webinar to be presented. So we partnered with the Tobacco Control Initiative, the assistant director of that program, and she did 2 webinars for us called Ask Advisor for a Guide to Tobacco Counseling. And that sort of is the abbreviated version of the CDC's 5 A's. So she presented that, and it was well received. We had not just providers, but also other healthcare entities really coming on board. The other thing we did was we promoted to our practices the physician office fax to quit referral forms. And that is a way to offer smoking cessation and support counselors for patients, and also closing the loop and provide the tracking to providers. So all of that kind of came out of that poster board and our messaging. Next slide, please. Some of the lessons learned, we found here we need to focus on one element to give providers a greater opportunity for success. We tied the message back to the ABC, but we pulled out the S, that smoking piece, that allows providers to really hone in on one element at a time. The other thing, we had to bring together key stakeholders who could offer providers in the community something. So again, the quit line is one. The tobacco initiative for smoke-free parks and smoke-free facilities help reinforce the message. We used data. We did do some data charts and provide the community as well as our providers with where they are with their patients who smoke, and also where their community is. And we need to expand the message beyond providers to allow the conversation to grow. And that's kind of how we keep tagging it. We want to grow the conversation and make it a part of the daily work that goes on. So that's how we're doing that, and thanks for listening.
Thank you, Carolyn. Our next presenter is Gail Bresco. Gail is from Ohio. She leads the Cardiovascular and EHR Learning and Action Networks for the prevention team with Ohio KeyPro, and brings with her broad-based knowledge in hospital advocacy and project management at the regional and statewide level. Welcome.
Thank you, Dr. Mims, for allowing us to share today. I'll describe our success story, which is in progress, G0446, Decoding the Code to Advance the Goals of the Million Hearts Initiative. Next slide. Our challenge was to engage our audience of primary care providers with an action-oriented strategy. Some background. In December 2011, CMS introduced a new reimbursable preventive service, HCPCS code G0446, defined as Intensive Behavioral Therapy for Cardiovascular Disease Risk Reduction, or IBT for CVD for short. It provides reimbursement for eligible providers to have a 15-minute face-to-face discussion with patients about cardiovascular risk reduction as a separate service, paid annually. Documentation for the service must include 3 components: advising appropriate aspirin therapy, measuring blood pressure, and discussing a healthy low-sodium diet. In essence, the service addresses the A, B, and C of the ABCs of cardiovascular health set forth by the Million Hearts Initiative. We saw this as a great tie-in to our project. Upon investigation, we found that concise resources and education were not available. We also learned from claims data offered by CGS, Ohio's Medicare Part B payer, that only 14 providers in Ohio had submitted a claim for IBT for CVD in all of 2012. Based on these findings, we decided to focus our strategy on creating awareness and promoting utilization of IBT for CVD. Next, please. Our key messages to engage providers made clear 3 points. You will be compensated for taking this extra time to counsel your patients. Providing the service is a measurable action which demonstrates physician-level commitment in advancing the goals of the Million Hearts Initiative. And Ohio's CV-LAN has developed resources to assist you in performing this service in your practice. Next slide, please. This slide describes our plan. After surveying the environment, we called upon our partners to assist in developing education. CGS provided clarification on coding and billing specifics, and our CV-LAN partners contributed clinical education resources. We combined all of these resources into a user-friendly electronic G0446 toolkit and quick reference sheet for our practices. Next, we piloted our intervention with a local practice. On June 6th, we provided on-site education during a weekly staff meeting to 2 providers and all 8 members of the practice staff. This face-to-face interaction was highly beneficial. During this collective discussion, the staff agreed as a team on how to build this service into their current office workflow. It was decided that IBP for CVD would be performed as a standalone service and also in conjunction with the current annual Medicare preventive visits. The practice will also use their EMR to identify eligible populations, alert providers when the service is due, and also use reports to recall eligible patients to schedule an appointment. We continue to work closely with them as they complete PDSA cycles of evaluation during the implementation to carefully record what works and what doesn't. We plan to share our resources and experience with all Ohio providers by October and the QIO community at large by the end of the year. Our ultimate goal is to see marked improvement in utilization rates for the code in 2013. Next slide, please. This slide shows the G0446 toolkit and quick reference guide that have been developed. Next slide. We are about 6 months into the project, and we've learned some lessons along the way. First, in working with our practices and CGS, we have found that Medicare preventive services are largely underutilized, and a need may exist for more thorough yet concise provider education on the specifics of administering the services. We have also learned that implementing a new code within a practice is a very complex process, requiring tweaks in the EHR, educating staff on necessary elements, and learning the instances of when a service may be administered with regard to other billable items. Next slide, please. We've also discovered some bright spots. Involving the entire practice as a team and drawing upon their past experience with implementing other Medicare preventive services were both keys to success. Also, role-specific documentation of the entire process is important. Recording sometimes overlooked details such as the amount of additional time or education required of the staff and necessary changes to the EMR will allow us to change this information to improve the implementation process for others. Finally, maximizing the functionality of the EMR is a great help through the use of preventive service alerts and system-generated reports for patient recall. We hope to have many more best practices to share as our project moves forward. Next slide, please. Please feel free to contact our team at Ohio Key Pro for further information and success story updates. Last slide. This concludes our presentation. Thank you very much.
Thank you, Gail. Our last panelist for today is Susie Burr, and Susie's with the Texas QIO. She's a registered nurse with over 20 years' experience, 10 of that in the clinical setting with much focus on cardiac. She's worked in the quality improvement area for the past 11 years and is currently a quality improvement consultant in physician offices across Northeast Texas. She's worked for TMS QIO for the past 9 years with a greater focus on EHRs and improving quality within their use. Susie?
Thank you, Joe and Dr. Mims, and for letting Texas be part of this call today. Next slide, please. Texas chose to share a little different. We chose to share about one of our larger systems and their success story in the cardiac focus, and they've actually helped push us above the recruitment areas. So we're focusing on them today. Health Texas Provider Network was formed as a partnership between a physician group and Baylor Healthcare System back in 1994.
They are a premier physician alliance, and they're very devoted to quality. They have over 610 physicians, 110 mid-levels, and in 2012, they saw more than 1.7 million patient visits. They're located primarily in the Dallas-Fort Worth Metroplex. Next slide, please. HCPN chooses specific quality measures annually to focus on system-wide. They look at the baseline the year ahead. So the baseline in 2011, they actually looked at was for diabetes patients with their LDL less than 100. At that time, they were meeting that at 57%, meeting it within range. So they chose that as their measure focus and started this focus heavily in July of 2012. Since diabetes and cardiac patients overlap so much, we decided rather than go on our own for LDLs separately that we would join them in this, knowing that it would benefit both types of patients. Their EHR system is set up for providers to obtain monthly reports on these measures that they can access at any time. The office-wide numbers are known throughout each site location as annual evaluation of each staff are tied to their performance. Even their front desk is aware of what measure they're looking at. Each office meets to determine how to best achieve these goals. Next slide, please. And they heavily utilize their MAs, and this has been very successful for them to assess the needs of each patient. Recently, within the last few months, they have developed what they call a just-in-time report to be used during huddles. Each provider and MA meet the evening before the next day to determine what needs to be done in the patient for the next day. Does the patient need the test? Do they need the LDL? Is it greater than 100? And if yes, what do their medications look like? When was their last change? They went a step further. In the fall of last year, they created a report in their EHR that shows any patient that has an LDL greater than 100 that has not had a medication change within 12 months. This report is accessible for any of the physicians. They can click on it and readily see which patients fall into this mix. They utilize clinical care coordinators who also look at this list and send letters and phone calls to get the patients to come in for their service. This has been really effective, especially for the larger, busier clinics. A few weeks ago, one of their needs that came up was the EHR documentation. Many office sites were not feeling the MAs were documenting in the right spots, and it's been going on for a while, but their EHR team is fairly small in comparison to how large the system is. They went ahead and developed short 3-minute videos specific to LDL. They have 3 out there. One is on the LDL process, one is on the workflow, and then one goes step by step on where to document, where to click. They are very excited about this. It did take a while to get going, so it was just released a few weeks ago. Next slide. They have found that improving LDL was actually more challenging than most things in previous, possibly because not only does it look at actually obtaining the test, it looks at getting that within range, which looks at medication regime and diet. Teamwork is very key, involving the entire office. Like I said, even the front desk. And the offices that have the most success here always have really heavy MA involvement in patient drill down. Data reports from the EHR, along with communication in the form of huddles, keep the patient's need at the front of mind awareness and produce the best results. Next slide. The baseline, like we talked about, was determined in 2011. And really the focus started heavily in July of 2012, which isn't representative on this chart. However, within 9 months' time, it went up to a 60% compliance, showing that diabetes patients that had LDL testing had 60% of them had their LDL within range. It actually shows a little more when you look at the patient volume. Basically, it shows that it improved about 2,400 patients more had their LDLs within range within that 9 months. And the system that they use, the EHR system, is always a few months or a little bit behind on the reporting. So we have confidence that it's improved even significantly since then, since much has been worked on heavily in 2013. They do Bridges to Excellence. They did have a few physicians last year in 2012 that did meet that for diabetes. So that is our presentation today. Thank you. Thank you, Susie. I would like to thank each of our 5 panelists again for such great presentations. We will now transition to our next speakers who will address identified barriers for the prevention and treatment of cardiovascular disease. The barriers discussion will be co-presented by Dr. Mims and Dr. Anthony Fletcher. Dr. Fletcher earned his medical degree from the University of Cincinnati College of Medicine. He trained in internal medicine at George Washington University Hospital in Washington, D.C., and then completed a fellowship in cardiology at Georgetown University Hospital. In 2007, Dr. Fletcher was named the National American Heart Association Physician of the Year. Welcome, Dr. Fletcher.
Thank you, Ms. Meekum. Dr. Mims, thank you for this opportunity. It's certainly a pleasure to address some of you this morning and some of you this afternoon since we have the time change here. But as a clinician in the field of cardiovascular medicine, these are very interesting times. In the practice of medicine, we've had changes with aging population and a diverse population that continues to evolve. We've also had changes in regulations and certainly in reimbursement, which certainly places significant challenges on the healthcare workforce. So I'd like to talk just briefly today about the challenges in improving cardiac health measures and clinicians' perspective. Next slide, please. An example of the challenge is the status of the ABCS. You know, one of the things as I was listening to various presentations, as a clinician, we are certainly used to acronyms and abbreviations, but I've heard PDSA, IPPE, MWZ, and if you put that with all the things we need to know about taking care of patients, that certainly is a challenge for many of us. But when we talk about the status of the ABCS, you know, we look at simple aspects of medical care: aspirin, blood pressure, cholesterol, and smoking. And we know that by modifying these particular risk factors and the use of the medication aspirin, we can make a significant change in healthcare outcomes. Unfortunately, when we look at the data that we are now starting to collect, we see, as based on the information that we have from the MMR, that only 47% of people are taking aspirin. And we know that people are at increased risk of cardiovascular disease, and we can minimize this by the use of aspirin. Blood pressure. People with hypertension have adequate control of blood pressure, but that's only about 46% of the population. And this doesn't even address the people who haven't been screened and appropriately diagnosed, who have untreated and undiagnosed hypertension. We talk about cholesterol. We know now there are many, many trials that have shown that cholesterol, both preventive and secondary prevention, makes a big difference. Only 33% of people with high cholesterol have adequate managed dyslipidemia. And smoking. Of course, people trying to quit smoking who get help, it's only 23% of the population. Next slide, please. The disparity in a diverse population certainly presents a major challenge. Even though we have guidelines and recommendations, we have to make sure that this is appropriately utilized in all populations. Diverse populations are inclusive of females, Afro-Americans, Hispanics, Asians, and the melting pot of the population that we have in this great United States. Unfortunately, the literature throughout shows many, many aspects of diverse populations not achieving the same level of care. For example, diverse populations are more likely not to be treated to the goal for chronic diseases such as discussed earlier today, hypertension and dyslipidemia. They're less likely to receive reperfusion therapy for acute myocardial infarction. They're less likely to have revascularization, even though the anatomy has been identified and proven to benefit from interventions such as percutaneous revascularization with devices and or coronary artery bypass graft surgery. They're less likely in the setting of poor LV function or sometimes even sudden death to receive a defibrillator, referred to as AICD since I don't want to contribute to the acronyms, and or revascularization therapy with resynchronization with complex pacing technology. The more likely to have a lower extremity amputation, in many cases not even with identification of the anatomy, the limb is lost, and lost permanently, which creates another form of significant disability. And the more likely, as we all know, to be underinsured and less educated. Next slide, please. I'm going to propose that we as a medical community could be awarded at large the Nobel Peace Prize for Medicine if we execute the following ideas. Education, education, education. Physicians and healthcare providers about the strong relationship between poverty and the environment. Patients about the need for lifestyle changes and preventive care. If you may, the Patient's Guide to a Living Strong and, Patient Guide to Living Long and Living Strong. Next slide, please. The tools that we can use to help us achieve this goal, the implementation of current and future guidelines. The AHA and ACC have worked very hard, for example, to come up with guidelines that will help us live longer and live stronger. Research inclusive of all diverse groups. Many of our clinical trials do not employ the number of females and or diverse groups in those studies. So we are actually extrapolating the data to assume that it works in all populations that we serve. We also are looking at genomics in terms of how different medications affect different populations with different gene subsets. An enhanced diverse group of primary care physicians is needed. We know that our current levels of medical school enrollment do not reflect the percentage of our diverse groups that we have in our population. And then also we need the availability of subspecialists as well as affordable, well-stocked pharmacies to service our patient population. Continuation of the tools, next slide. We need available, healthy, and affordable food choices. We know the right foods now, but sometimes they are not available in the communities that need them the most. And sometimes, as we all know, the healthier foods are much more expensive. It's kind of hard when you're on a limited budget. We need the appropriate facilities to accommodate exercise needs for all. Prime example, we have many people in rural Arkansas, and I'm sure rural Ohio and Texas are no different, where people cannot walk because of lack of appropriate safe areas to walk. They might need water aerobics, but there are no local swimming pools available where they can go get these aerobics. So we need to investigate that as we talk about weight reduction and exercise for enhancement of overall conditioning. We need the appropriate risk stratification so that providers are not penalized for caring for the sicker patients. We're starting to look at reporting of results, reporting of statistics. A physician who takes on sicker patients many times would be penalized for taking care of those patients because his or her statistics may not show that ideal morbidity mortality statistic. So we need to adequately look at that. Even though we say the database is risk stratified, in many cases it truly is not. Next slide, please. We talk about justice. Justice in the United States is equal care for everyone. And I'd like to share as I close this quote. Of all the forms of inequality, injustice in health care is the most shocking and inhumane. The late Dr. Martin Luther King. I thank you for this opportunity.
Thank you, Dr. Fletcher. And now we will return to Dr. Mims for her presentation on disclosing some barriers and issues as well. Dr. Mims?
Thank you, Jill. And, you know, it's a pleasure to be participating with you all on the call today. And as the medical director here at Alliant GMCF, I work across all of the aims. I am particularly excited about being in C9 when I first saw it being listed because I'm initially a primary care practitioner and I knew that a lot of this work was going to work with us in primary care. So my focus today is to talk about some of the barriers that we've been facing within this particular aim. And I'm going to focus my discussion in the three main areas. And I like the fact that these pictures really depict how we're actually approaching this. We're going to talk about the physicians and the clinicians who deliver the care and the challenges that we're seeing. And I think that most of my presentation is going to elaborate on what Dr. Fletcher has said from a different perspective, because I'm going to come from the perspective not as a clinician as he did, but more from those of us who are working in the area of quality improvement, working with the clinicians. I'll then focus on the perspective of the patient, again, from a different perspective than he is. I think that we're adding and complementing each other quite well with our identification of the barriers. And then I will discuss more about the system approach to barriers that we have all faced as we've addressed this cardiovascular prevention across the state. Next slide. So let's talk about the physicians. Well, number one, when we talk about being within the Medicare environment, we know that there's a growing population of seniors. My background is one of geriatrics, and in all of our presentations, we talk about this wave of seniors or the geriatric tsunami that's hitting across the United States. The wonderful thing about this particular initiative was that our focus was not only on seniors, but those of the general population that our providers were seeing, or the communities in which our people live. So this allowed us to not just talk about care and try to do secondary prevention among those patients, but also to look at primary prevention among the community at large. But the physicians were not necessarily trained in the area of geriatrics. And so seeing this wave of aging patients has put a challenge on their experience and how to address this, especially those who are living so much longer with multiple comorbidities. In fact, they don't have enough time. As you look at the time that physicians spend with patients, and surveys have shown that appointment time slot has only shrunken over time. Used to be an hour, then 30 minutes, 20 minutes. And I know those of you on the phone, your experience may have been that it may have been shorter than that, maybe 6 minutes that you saw face-to-face with the physician. Well, a lot of what we're trying to do here within cardiovascular prevention is behavior change. And in order to do behavior change, we have to assess their stages of change. And that does take a dialogue. It takes a good conversation to be able to elicit the patient's feelings where they currently are. And it takes time for working with them to allow them to set their goals. We know there's some give and take, and explaining with them some of the barriers so that they can make a realistic goal. We talk about from our PDSA project that we need a SMART goal, one that is specific, measurable, attainable, realistic, and timely. When we work with our patients, we want them to have a SMART goal too, but we know that that takes time. When we work with our patients, we're used to seeing them in our clinic setting, but the clinician is only seeing them in their clinic, and they're not quite sure what their in-home support system is like. Is it many people living within that one environment, or are they alone and have limited resources? We know that within this realm that we're dealing with, aspirin is inexpensive, but blood pressure control and cholesterol control can be costly in terms of the number of medications. We know that once a person is diagnosed with high blood pressure, over time we would need to increase the rigor of their blood pressure control, and often that may need more medication. Also with the physician, they're used to working in an episodic care environment. Each time you go into the room, the next patient is coming in for another acute problem. And not often are they really geared toward their practice in a longitudinal approach. And so when you look at the physician perspective, you have these major barriers in their ability to be very proactive and take the time to get the patient on board with the care plan. On this next slide here, we're talking about the patient. And the patient that we are working with, as was mentioned by Dr. Fletcher, when we talk about cardiovascular control, we're talking about a wide, diverse group of patients. And some of our literature and some of our approaches may not be culturally or linguistically appropriate that we have available in our offices. So since we're talking about cardiovascular prevention, a lot of that is dietary. And dietary changes based on your culture, whether it's a Southern diet, an Asian diet, a Hispanic diet. We would need to carefully advise them on the changes that would make a difference with their cardiovascular protection based on diet. And we do not always have the resources to do a culturally and linguistically sensitive approach. We know that some ethnic minorities are more predisposed to metabolic syndrome or obesity. Well, whether this is racial, genetic, if it's environmental, there's a lot of factors there, but obesity and the metabolic syndrome is a predisposition to all of the things that we're talking about that we're trying to control with this. And then, again, from the patient perspective, when we're going in and trying to approach them, we're singularly-minded thinking about this one condition. But we don't know what kind of support that they may have. Are they really involved in their church? Are they also parenting or grandparenting and being the primary caregiver for people at home who also have dementia? Are they trying to support many other people on this one salary? So that makes it a challenge for them to focus in on their health, especially with these chronic diseases that are without symptoms. You don't really know if your blood pressure is not at goal or if your cholesterol is not at goal. But smoking cessation, that is something that they can focus in on. We need to have more tools for self-monitoring. We have noticed very quickly with the control of diabetes that when you give the patient the ability to check their blood sugar at home after they've exercised, after they've eaten certain items, there is a tendency for the patients to begin to modify their behavior. It's their ability to begin to step up and become more involved in their care because they can see very quickly the outcome of what they're experiencing. And so being able to have more being able to engage the patient with some self-monitoring tools that they can do for this initiative would be valuable. Being able to check your blood pressure at home, having a home blood pressure monitor would be nice. But even if we are able to facilitate the patients going to the fire department or the local drugstore to get that done, that would be helpful. But the quicker that they can have access to the blood pressure reading in relationship to their behaviors, the more likely they're able to modify it and get that immediate feedback. So that would be something that would be of value to them that they don't have access to. And the last part for patient engagement is access to care. And, you know, as you have been on the phone and on the webinar, have been working within the communities, we realize that one of our focuses is those who are Medicare, but when we look at the area of the community at large, there are many people who have no access to insurance at all, and those who are underinsured. They can't even come in for a medical visit. And then those who are insured, they're not able to take off time to come in for an appointment. And so our patients will have barriers in terms of accessing the care and then accessing the medications that may be prescribed. They may have difficulty accessing the foods that are prescribed within this diet too. So there are many barriers for the patient in the prevention and management of cardiovascular disease. And the last area I'm going to talk about more here is in systems. And in each one of the areas that you described from your success stories, across the country, you're involved in various systems. And we realize that there are some gaps. There are some extensive needs for behavior management within our patients. And a lot of that behavior management would be in counseling. We know that there is for diabetes patients to get dietary counseling from a nutritionist, and that is covered by Medicare. But a lot of counseling for this initiative previously had not been covered. I learned on the call today about GO446, and I hope everybody else will take that back and be able to promote the ability to be able to do counseling within the system. But as you have in your state, Ohio, begin to promote that, you realize that most of the country is not aware of that resource, and we're very happy to have learned on this call something that we can promote to many other people. In addition to that, are there ways that we can collaborate with people within our communities that we can then provide more access to our patients to getting home monitoring? Well, we know that this is not covered by Medicare. Are there other types of systems that are available, whether they're grant programs or community-based services, that we can assist and collaborate with to get the patients these monitoring devices that would be so needed for them? In addition to that, what about patients who have other insurances? One specifically is dually eligible patients who are Medicare and Medicaid combined. A lot of patients who could be on Medicaid are not aware of it. And so they're using only their Medicare benefit, But the Medicaid combined to Medicare can enhance their access to medication, transportation, and sometimes in-home support services that may be helpful. So there are many other things that we can do to provide access to our patients looking at the current system. And what's not on this slide, and I think one of the major system changes that we can begin to look at going forward is how the healthcare system is structured. It is still on a basis of who comes to the doctor or clinician when they feel that there is a problem. And if we're able to begin to modify things to be more patient-centered, such as the patient-centered approach to medical care or patient-centered medical home, that will allow patients to have more access to care based on how they feel that they need it. So thank you for being able to be part of the presentations today, and I will turn the facilitated discussion back over to Joe at this time.
Thank you, Dr. Mims, and thank you, Dr. Fletcher. We will now open the mics and chat lines for further discussion. We would like to encourage the use of the chat feature to ask questions, but if you're unable to use this feature, please use your *6* to unmute your line and ask your question. For those of you phoning in questions, once you have asked the question, please then remute your line by using *6* code or the mute button on your phone.
And Joe, I wanted to start, Dr. Mims, I had a question to start with that G code 0446. I wanted to get some feedback of other people who have been promoting that and what the providers have said regarding the reimbursement of that and how receptive have they been in using it.
Dr. Mims, again, this is Gail Gresko from Ohio. In our presentation, what we did mention, and was kind of alarming, was that only 14 providers in the state of Ohio in 2012 actually billed that code. And so that was probably one of the reasons and the impetus for us to move forward with educating our providers on this code, because what we found in Ohio, I think that equates to about $20 to $25 to conduct that additional counseling. And actually, when we met with our practice and our pilot practice, the physician there said that generally his conversation with his patients, they do talk about aspirin therapy. They always get a blood pressure. And so obviously, if they would just want to bring up the idea of a low-sodium, low-fat diet. So, and it's dependent as how much in each state, it's determined, I think, statewide as to how they're reimbursed.
So, Gail, could you just add on to that? Could non-physicians actually go for this code?
If you go to the guidelines, there are a group of providers that are covered, yes. Non-physicians, nurse practitioners are covered, and other medical staff. It's just like a team, approach. And that's why you want to educate, because you can have part of your staff do education on, say, the DASH diet. So combining all of those, the different disciplines and team, yes, they are involved in it.
And then last question, are they able to use that code for a group visit?
For a group visit. Carol Savager here is with me.
I apologize. We're passing an actual handheld telephone back and forth today. We did touch briefly on a group visit and incorporating the code into a group visit type of workflow. I think it would work really well in that setting. So that's something that we'll be looking into as well and should be able to share with the rest of the group.
Thank you.
Dr. Mims, this is Donna Branch in Maryland. Just 2 weeks ago, we did a face-to-face meeting with our DC participants in the land, and we shared information about this code. In fact, the whole meeting was about the code. And we were very surprised to find out that the code had only been used 5 times in D.C. by 2 providers. So there's a real need to get the word out.
Well, that's great. Do other people on the phone want to weigh in on ideas they have about getting the word out about the code?
Hi, Dr. Mims. And we have used this information at all our webinars. We have an ECW user group, an EHR user group, and then we have a performance improvement acceleration group going. So with that, we share that information as an announcement on every webinar. We have it posted on our website, and we're putting that information in a mail out pretty soon to some of our rec people who have not yet participated. So it's valuable information, I agree.
That's excellent, and how you've demonstrated that you're using that across AIMS, across the AIM, not just part of the cardiovascular part. Was somebody else weighing in?
Hi, Dr. Mims. This is Carolyn from New Jersey. We've been doing similar by pushing that out to our providers. We actually go use that when we're at our on-site visits to work with them on how to implement it within their EHR so they're documenting appropriately. The one catch in New Jersey we've come into, our carrier is not paying those claims. And we're getting some conflicting error messages, so we are working with them to figure out why they're being denied for some providers but yet paid for others when the message has been the same. But it's very important. It's been really amazing to get kind of build the awareness. And we do constant contact messaging, so we do consistently remind our providers of all the preventive services G-codes that are available for them to use and how to use them appropriately.
Great, thank you. Other thoughts on the phone?
This is Devin from Colorado. We use a similar method. We have a handout flyer that we bring to the practices, and then also try to incorporate the information into the electronic health record.
Thank you. I see a question here. Can the code be used on more than one visit or only once in 12 months per patient? Can someone answer that question? Gail, if you're on mute.
Can you hear me now? I apologize.
Okay.
This is Carol Savader with Ohio T-Pro. I saw Dr. James's question there, asking if the code can be used on more than one visit. No, all of the required components that need to be documented do need to be provided in the same visit. I think that was the first part of the question. And yes, the service may only be billed once per patient per 12 months. So it's annual.
Thank you.
Thanks for your question. I see here another question. For those who ask, Medicare will not pay G0446 separately with another encounter when billed on the same day. I'm wondering, Ms. Brown, if you would be able to chime in and let us know, because it does indicate in the claims transmittal manual that it can be billed with another Medicare wellness visit with the use of the modifier 59.
And Ms. Brown, you can do *6* to verbally give your answer. I did want to throw out another question while we're trying with this. Have other of you worked within people's electronic health record to implement some of the best practices that you've been talking about today?
This is Devin in Colorado. I'm sorry, I couldn't hear your question.
Okay, I was going to say, within this cardiovascular improvement, I wondered if any people on the line have worked within the group's electronic health record for enhancement to support the system. And I'll let you think on that while I give you one example of what we did in Georgia. We were working with a federally qualified health center, and they were on eClinical, ECW, And within Georgia, for smoking cessation, they have a fax-back referral form to the quit line, the tobacco quit line. And if the provider uses the fax-back form for the quit line, the patient will be called from the quit line at the time of day that they request by on the cell phone if they'd like. And they would also be offered nicotine replacement therapy. So our providers within ECW at this particular facility figured out how to put that fax as a form within the electronic health record that the patient can sign on the screen and fax it from their electronic health record system. They're now teaching others within their federally qualified health center who are also in ECW how to do this. So I wondered if other people had examples of how they're using technology of the electronic health record to support work within the same. If those on the line would like to speak, you would press *6* to unmute your line.
This is Susie. I think we talked about it a little bit in our talk, but probably the big thing in the EHR, like the LDL report that actually drills down on information that's greater than 100 that has not had a medication change within the past 12 months, has been very key, and that is an EHR report, and it's been one of the most helpful within the system we discussed.
And how often do you give them that report?
Actually, the way that HTPN has it is the reports are accessible on the computers to all providers at all times. So they can, anytime when the patient's there or anytime if they're sitting at their desk, they can at any time access that report. It's updated monthly.
That's great. Thank you.
Mm-hmm.
In Colorado, we've tried to create an alert or a flow sheet for cardiovascular health based on either the diabetes diagnosis or hypertension diagnosis, and then put the measures in that should be done in what time frame, so that when the patient does come in, those alerts pop up to the provider or sometimes the medical assistant if they open it up first.
Mm-hmm. Great. I don't want to be the only one asking questions, so I'll turn it over to others who would like to ask questions of the participants or those on the line. And if you're making comments in the chat line, you can do *6* to open your line to verbally present that. I see a question here about the medication reconciliation code. There is a PQRS measure, a reporting measure that clinicians can get enhanced reimbursement on, and it is medication reconciliation, and that is one of the geriatric care measures. They're looking specifically for patients who have been discharged from the hospital, whether or not the outpatient clinician is reconciling those medications. And it's especially important within the area of cardiovascular disease, because if your patients go into the hospital and their blood pressure is not quite as it had been, by the time that they're discharged, another medication may be added. They may have had it written as a generic medication, and all of a sudden you find your patients on multiple medicines. So one thing that would be helpful to do is to assist your patients by giving them medication bags. In Georgia, that's one of the aspects that we chose to do, is promoting a best practice to the federally qualified health centers. Their patients on multiple medications, in addition to trying to get them to check their blood pressure outside of the clinic setting and log it on a sheet of paper and bring in all of their medications. You know, I'm going to put on my clinician hat for just a second here, because I also do clinical practice. When a patient comes in the room and you check their blood pressure and the blood pressure is high, you know the very first thing they're going to say, oh, it's not always up like this, or I ate something this morning, or I'm nervous, or I have white coat syndrome. I have found that by giving the patient a log or a sheet of paper where they can check their blood pressure different times a day and in different locations several times before they bring it back to me, I will be able to have a perspective of where this blood pressure sits in relationship to the rest of their blood pressures. And so that is another tool that we've been able to use and promote. At the same time, having patients bring in their medications in a bag, I find that helpful because if you have patients bring in a list of medicines or you ask them for that list of medicines, they invariably bring out that crumply sheet of paper that has been written on many times, and they feel that this is your list as opposed to specifically their list unless they typed it up themselves. And if you begin to ask them, what about this particular drug, they'll ask you, is this a pain pill or not? And so if they actually have the bottles that they've paid for and that they're using every day, and they bring that into you and show you what they're taking, they can relate better to which pill is for which reason. So I find that it's a good safety thing to bring the medications into the visit. So I'll stop there and open it back up to others for questions and comments.
Lucy, this is Jo. Can you talk a little bit more about HTPN's use of care coordinators?
Yes, this is Susie with Texas. They actually house their care coordinators remotely from the clinic, so they're not actually located on site. So their primary job is care coordination for all the different locations. It has been varied. They've used them for quite some time in their preventive services, and I've heard varying opinions on that, depending on how large or small the location site is. Actually, the large sites that are just really busy, the clinics, the charity clinics, those sites it seems to work really well in. The sites that maybe are smaller and maybe all the staff knows the patients by name, may not recognize the name of the care coordinator when they call or send a letter, and so sometimes they've had a little bit of resistance with the name, not understanding why this person they don't know is contacting them. But overall, it's been highly successful. And they primarily do look for those patients chronic disease type patients that have not been in for quite some time or that need to come in for testing and try to get them in for scheduling an appointment.
Thanks. Are the care coordinators actually part or assigned to a care team?
They do have, because the system is so large, they do have care coordinators that actually, they're somewhat of like regionalized. So yes. That is true. They are part of the care team, and they do contact the office manager. They have a contact system that they can contact directly back and forth, like a messaging type system. So they are part of the care team, yes. They do cover more than one location.
Thank you. This is Jo again. Carolyn, there's a question for you. Did anyone request or use your referral form that you discussed?
Hi. Yes, actually they did. Similar to what Dr. Mims described, we have a couple providers and practices that have implemented an electronic version of that form in their EHR and are using it through their care coordinators because they're a patient-centered medical home. So what they're doing is they're utilizing that to send directly over to New Jersey Quitline and or Moms Quick Connect if we have two entities. So they're faxing that directly from their EHR, and that's being sent over, and then they're getting the tracking piece back because of that, since it's branded with their information, directly sent back to them so they can monitor their patient outcomes, whether they're following up. The other side to this is we're also working with some of our practices wanted a little bit more engagement. So Pfizer they have a research end that actually does a lot of smoking counseling, behavioral health change work here, and they've been going to practices and providing them with information and training programs on how to better engage their patients to quit smoking. So that's another piece, and they have actually assessment forms that one of our practices has built in that they can actually do a little bit more detailed questionnaire depending on the patient's level of smoking. And then from there, refer them or do the appropriate counseling that's needed. And we are promoting, of course, to our practices, billing of the smoking counseling codes. So that's another big piece that, again, Preventive Services is trying to engage with that.
Thank you.
Did she say Pfizer or Kaiser?
I'm sorry, Dr. Min?
Did she say Pfizer or
Yes.
Kaiser?
Pfizer, the farm. They actually have an Advice to Quit Plus program that's not about promoting any medication or anything. It's more about engaging in that conversation and providing materials to really help practices understand how to develop a smoking cessation program. It does focus on tobacco, but they've got a lot of wonderful resources. One of the things they sent us was a flyer on knowing what to expect when you quit smoking, understanding the benefits of smoking, and it's the cost-related things where, the patient can fill it out. But another thing is My Health account, knowing why you smoke and understanding. So they give a lot of good materials for a practice. So again, it's sort of us leading a practice to that resource where they could get that little bit more intense training, because practices here we find are struggling. They're advising their patients, but they're not seeing marked results. And, as the presentation showed, 23%, that's our number. We still need to, improve. We have a significant way to go.
Mr. Anthony Fletcher, a question I have, do we have any data about how much penetration of these preventive codes actually exist in the real world? I think that would be very valuable. And then once we know that number, if it's as small as I assume that it is, then we need to think of some ideas as to how to improve the penetration of that data.
Thank you, Dr. Fletcher. That's an excellent comment. I know in Georgia we have not tried to find out about that, but I think as the QIOs we may have access to some analytics that may be able to give us some information on that. And Annette Kuzma was previously on the line. If she's not still there, that may be something she can answer for us, if that is a particular piece of data that is available statewide or national, so that we can look at how we can enhance that. And I had a different question, if others could weigh in on. Earlier, it was a comment about smoking cessation, and I appreciate the resources that were done there. But I wondered if others had different approaches to smoking cessation on either rural populations or minorities that were different that we haven't heard about so far.
Dr. Mims, Anthony Fletcher again. One of the practices that we use in our practice is the realization of, pseudo-scare tactics to have the patient understand that they are significantly contributing to their poor health. And I do it in a sort of a jestful fashion in that we talk about sometimes the fact that they have already contributed to the education of my child, and she's about ready to graduate from high school. And at this point in time, if they continue to smoke, they'll continue to contribute to her college education fund. And it sounds like a sort of a silly story, but I've had people actually approach me in the outside world and say, I stopped smoking because I'm not going to contribute to sending your child to school. I've got my own, and I won't use the expletive, but I have my own children that I need to send to school. But I think what it does is it helps the patient realize that you're not just there as an agitator, because they expect you to say don't smoke. And so rather than come in with the comment of, yes, you should stop smoking, or yes, you should lose weight, you try to make it real to the patient in a fashion that they can relate and understand to. And it's actually quite effective. We've had quite a significant success in people who've made a major effort in tobacco cessation.
Thank you very much. Spoken from a great clinician.
Thank you.
Great. Does other people have some QI methodology that you've been using to promote the smoking cessation part? And then after that, I wanted to know about aspirin use. So we can go straight to aspirin use if people have had some successes in implementing the aspirin part of this particular initiative.
Again, Anthony Fletcher, I think the EMR has been very helpful in that it certainly raises the question, both in the hospital side and in the office side, that there is or is not compliance with the utilization of aspirin. In our particular facilities, our numbers have gone up to the 90th percentile in most cases. And unfortunately, sometimes with some of the hospital-based employment practices that are now being utilized across the country for cardiologists, that is actually an incentive for reimbursement. Your RVU could be adjusted upward or downward based on your compliance. And so certainly EMR has played a major role in aspirin utilization.
Thank you very much. Were there other comments about how you've been able to promote the aspirin use?
This is Susie in Texas. Several of our practices, the physicians seem to actually recommend aspirin, and patients are on it, but lots of times maybe it was getting missed on the EHR since it's not an actual prescription. So some of our practices, it's just been an education system to start with the triage process when they come in to find out what medications they're on, but also to make sure and drill down a little further to make sure they're capturing aspirin and actually writing it in the medication area to capture into the reporting part. And that's really helped the reports to show actual aspirin use. So for us, we've seen a lot of it's an education issue for the staff to make sure it's actually getting inputted into the EHR.
The other part of that, too, is that sometimes patients don't even think that's a medication. When you ask them for their list of medicines, they don't list aspirin as one of their medications, so you have to really be specific to ask that question.
Excellent. Other thoughts from the audience? A lot of the work that we do has this collaboration across different organizations. And I know, Janetta, you had a lot of collaboration within your initiative. How did you get the State Department of Health to be involved? And how did you decide on who was doing which role?
I'm sorry, Dr. Menz, I had a little trouble unmuting. It started out actually with our care transitions team that was actually meeting regularly with the state and kind of involved the C9 team in, let's see what we can do to work together. That's how it began and kind of blossomed into what kinds of things can we do. And the state had gotten information from CDC regarding working with QIOs on collaborating for Million Hearts campaign and kind of reached out to us. And the partnership just bloomed from there.
This is Jo in Arkansas. We've just got an incredible partnership with our health department here, and one of the things that we do that's been such a great fit is working together on a chronic illness collaborative. And we have two tracks. One is specific to cardiovascular disease, and the other is diabetes. And the next one, we're talking about breaking out and having a third track that is very specific to hypertension. And it really helps us get the messaging out and work at the provider level, practice level. So it's been a great working relationship.
So can you talk a little bit more about your community work and some of your community partners?
Oh, wow. It's one thing that I can talk and talk on. We have just enjoyed this piece of the contract work tremendously, and CMS allowing us to just really be innovative and broaden our reach. We have some unique partnerships in Arkansas, and one is the partnership that we have with the National Park Services. And it just so happens when we approach them that they also have another national initiative called Healthy Parks, Healthy People. And so we've kind of married the two national initiatives and really done a lot of focus on increased physical activity and smoking cessation, things that are just relevant to the prevention of cardiovascular disease. We also are working with, have a lot of focus on using our health ministries toolkit specific to cardiovascular disease, and we're working through the churches and their health ministry programs. That has enabled us to reach a tremendous number of minority populations. And one of the things that we're finding is that, particularly with the Hispanic population, there's such a trusted relationship with their priest and their church members. That's just about the only way that we're able to really reach out to them. And the response has just been tremendous. So those are some of the things we're doing.
Thank you. Would others on the phone or on the webinar like to share? You would press *6* to share or ask a question.
This is Anna in Texas, and I just wanted to say that some of our partnerships, statewide partnerships, have been really successful on Million Hearts Initiative. We've been working very closely with the Texas Department of State Health Services, and they have a cardiovascular and stroke partnership committee that they've developed, and where they recruited me to be the chair for the Healthcare Interventions Committee. And so I've worked very closely with other people throughout the state on the issue of cardiovascular disease and stroke. And then we've also, I made sure to invite them when we meet with other partners. For example, when we recently met with the UT School of Pharmacy, and we met with them on the issue of Team Up, Pressure Down, trying to get connections throughout the state with the Texas Pharmacy Association. And they've given us great leads to, Walgreens, Texas Pharmacy Association, and other types of pharmacists throughout Texas. And we're just now working on that. But that's kind of how we're developing this issue in Texas.
This is Devin in Colorado, and one of the funnest collaborations that we had in Colorado was with the University of Colorado. They're doing a program called Boot Camp Translation, and they go into a neighborhood and they ask for volunteers to actually learn about hypertension and what it is and what causes it at a pretty in-depth level. And then this group actually is in charge of creating a message for that community to reach out to the rest of the community in terms of managing hypertension. So that was a really fun program that I got to participate in, because I got to go to the meetings. And right now they're finalizing their final message.
Well, that's great. And Devin, if you can share some resources on that. I'm looking at the time, and this has been a great conversation. I'm about at the end of the hour. Thank you all for the presenters who have taken their time out to share their best practices. A special thank you to Erica, who pulled all these groups together and collaborated on their slides and has been a wonderful support for this initiative. I want to specifically thank Joe Nickham, who agreed to facilitate for today, and her medical director, who volunteered her on her behalf. Thank you very much all for joining the call. As you end the call, you will see a pop-up, which will be the survey that is an evaluation for the call. We appreciate your feedback. And everyone who logs into the call and the webinar, everyone who logs into the webinar will receive a copy of the slides. If you log in only to the call but not the webinar, you can email me and I can send you a copy of the slides, and that's adrian.mims@gmcf.org. As I said before, this is a series of presentations, so we do have additional ones in July on end-of-life care planning, value-based purchasing, and patient and family engagement. In August, we hope to have a presentation on reduction of antipsychotic use. And you can see how your role would be important there, too. So thank you for joining us.
Thank you, Dr. Mims.